Good day to you all. Thank you for inviting me to speak on your Bing Neel Support Group meeting this year. My name is Dr. Monique Minnema. I work as a hematologist at the UMC Utrecht Medical Center in the Netherlands, in Utrecht. And I'm happy to share some knowledge that I gained over the years about this disease that you all are afflicted with. So why the name? I think this is a story you heard before, but for us in medicine, it's quite strange that there are still some type of diseases that are not having medical scientific names, but are named after persons. So that's the game with Waldenström's microglobulinemia, named after Jan Waldenström, but also the case with Bing Neel syndrome, named after Jens Bing and Axel van Niel, who first described this phenotype in 1936. And they described a disease with neurological deficits, a hyperglobulinemia. There were lymphocytes or plasma cells in the central nervous system. And while Waldenström's was only described in 1944, this was previous to the Waldenström description. So really they did not know that the two diseases were linked. So what is the relation with Waldenström's disease? And the big thing is that it's the same type of cancer cells. So both in Bing Neel syndrome as in Waldenström's disease, the cancer cell is a late stage B lymphocyte, and that is transformed into a cancer cell due to new mutations that derived during lifetime, during their development. So late stage B lymphocytes means that there are B lymphocytes that have a specific task, and that is to produce immunoglobulins. And when you have a cancer cell, a B lymphocyte cancer cell, it will produce the same immunoglobulin in fast amounts, because you have many of this same cell. And then we can see it in the bloodstream, and we don't call it a standard immunoglobulin anymore, but we call it a monoclonal protein. And with Waldenström's disease, as with BNS, it's an IgM type monoclonal protein. These cells mostly carry the MYD88 mutation that has been described by Steve Trion many years ago. And the big difference, therefore, is that it's the same cell, but with Waldenström's disease, these cells are in the bone marrow, in your spleen, in lymph nodes, or perhaps on other sites in your body, but they're not in the central nervous system. And in Bing Neel syndrome, these cells are inside the central nervous system. So that's the big difference between the two diseases. And we have defined Bing Neel syndrome as having infiltration of malignant Waldenström cells into the central nervous system, and they are preferably in the meninges. And the meninges are the layers that surround your brain. They form some kind of protection for your brain, and these are very strong but thin layers around your brain. And that's the case where most of the Bing Neel patients suffer from, is that they have localization of the Waldenström cells into the meninges. It's very important to distinguish this disease from IgM peripheral neuropathy, because that's a disease mostly almost always located in the peripheral nervous system, so not central, but peripheral nervous system. And it's not the cells that invade the nervous system, but it's the M protein that is produced by the cells that have a reactivity to the some components of the peripheral nerve. So it's a very different disease, but also the mechanism of disease is quite different. So what is your central nervous system? It's composed of more than only your brain. So this is your brain, and it has the meninges surrounding that. So that's what most people know, but also your complete spinal cord all the way down is a part of your central nervous system. your eyes, and also the optic nerve from your eye to your brain is a part of the central nervous system. And of course, the cerebrospinal fluid, the CSF, that's surrounding all your brains on the outside, but also here on the inside, is all part of the central nervous system. In Bing Neel syndrome, it's more rare to have optic or eye involvement, and also more rare to have an intracerebral tumor. So the meninges are preferably the location of Bing Neel syndrome. The clinical picture, however, is extremely heterogeneous. So there is no specific sign or symptoms or combination that can help the physician to determine that it's Bing Neel syndrome. The most common signs that have been reported in literature are an altered mental status, including memory loss, cranial nerve disorders, but also paraplegia, paralysis, that you can't move your legs and arms, and an unsteady gait has been reported. In about 1/3 of patients, also headaches, nausea, vomiting has been reported, paresthesia, so tingling, looking a bit like neuropathy, seizures and limb pain, and less frequently are psychiatric symptoms, a blurry vision and hearing loss complaints that in the end pointed to Bing Neel syndrome. So optical presentations are quite rare. Myself, I haven't seen any patient with an optical presentation until now, but as also the title of this publication demonstrates, it's very difficult to diagnose Bing Neel syndrome in the eye, because if you look at the eye, this is on the front of the eye, so this is your lens, so here you can see, and here all the information is scattered, and here's your optic nerve, and your optic nerve will take all the information from your eyes to a part in your brain where you actually do all the seeing that we do. So the eye is itself also a very complex organ, and most of the Bing Neel presentations that I could read of in literature are localizations here in this optic nerve. So therefore, it's very difficult to diagnose. It's not a lymphoma here inside the eye, but mostly outside the eye. So I can imagine that perhaps this is also an underdiagnosed feature in Bing Neel syndrome. So what are the differences between meningeal versus the brain, more in the brain localized tumors? Of course, people can have a combined feature of that, but if it's separate, we do think that meningeal is more frequent in BNS, and the symptoms of headaches, nausea, vomiting, visual disturbances, hearing loss, but also the cranial neuropathies are more common in meningeal localizations, while in tumor localizations you more have paresis, seizures, aphasia, so that you can't speak, the psychiatric symptoms, and also the cerebral dysfunction, so your small brains that are very important for your balance, and also impairment of consciousness, including coma, is perhaps more seen with the tumors type inside your brain. Well, in both disease presentations, a contrast-enhanced MRI is extremely important for the diagnosis. And here you see two pictures of meningeal and both a tumoral form of the Bing Neel syndrome. This is a form where you can see the thickening of the meningeal sheets, so they are outside your brain, but also here they will encapsulate your small brains. So here you can see a very clear example of a thickening of the meningeal sheets. And here you see a clear example of a tumor that's inside your brain. If you look at the pictures, here's the nose, here are the eyes, and here's the back of your head. And this MRI image is a bit lower than this MRI image. So therefore you see also the small brains in this one. So we think, we estimate that perhaps at the max 1% of all Waldenström patients will experience or have experienced Bing Neel syndrome in conjunction with Waldenström's disease. Until now, no prospective studies has been done. And with prospective, we mean that we have a plan beforehand, that we will say we will collect all the information or this type of information or this type of treatment that we want on Bing Neel patients. And prospective studies are always more precise than retrospective studies when you look back and say, well, let's see how many patients we had in the last 10 years in several institutes. But until now, no prospective studies have been done, but many patients have been reported in the literature, sometimes as a solitary patient, but sometimes in larger reports. For example, from the United States or France, we have some larger groups of reports that we can make some more definite conclusions on. Importantly, that Bing Neel syndrome can be the presenting symptom in patients that also have Waldenström's disease, but did not know that before they were diagnosed with Bing Neel syndrome. So in 15 to 36% of patients, Bing Neel is diagnosed before the diagnosis of Waldenström's disease is made. And very important, especially in patients who do have Waldenström's disease, Bing Neel syndrome can be present without any other evidence of active or progression of systemic Waldenström's disease. So your Waldenström can be treated or not treated, but is in remission, and then suddenly you can develop symptoms of Bing Neel syndrome. But also in 99% of the patients will never develop Bing Neel syndrome. So in most cases, with Waldenström patients with new neurological complaints, we also have to think about other reasons for their complaints, and it's not always Bing Neel syndrome. So living with Bing Neel syndrome has two aspects to it, I think. As in Waldenström's disease, there are no definitive curative treatments. And it means that when you get the diagnosis, it will never leave you. And you have to try to incorporate in some way this disease into your life. The treatment that we give is aimed at killing the cancer cells. That's the treatment that hematologists give. And you have to be in constant care because relapses can occur. And if relapses occur, they are mostly slowly progressing. So it's important that you know your body, that you know your symptoms, and that you can distinguish new symptoms that are perhaps developing in some weeks or months, but that you know this is something that I did not have like 2 or 3 months before. So keep track of your symptoms and really know what belongs to a steady state Bing Neel syndrome or perhaps a progressive form of Bing Neel syndrome. The other thing is that, as in other brain diseases, the resolution of symptoms is mostly partial. And that's because there's a low regenerative capacity of neural cells. They are not like your cells in the bone marrow or like cells in your mucosa that they fight with millions a day. And when you attack them, they have stem cells and they will form new cells. But it's not the case with neural cells. They are non-dividing or dividing very slowly. So we live with the neural cells that we already are given to us by birth or by conception. So that means that if they are attacked or damaged, they can heal, they can be better, they can recover, but in most cases it's only partial, and most patients will remain with some complaints of their neurological system. And I do think that the hematologist is not the best person for helping people with problems of their neurological symptoms. So I think symptom management can be done by a neurologist, but I think especially the rehabilitation experts are more important to help people, for example, walk again or try to live with their neurological deficits that they have gained with an active episode of Bing Neel syndrome. And I would like, perhaps I was a bit pessimistic with the last slide, and I would like to share a patient's history from a patient that I really already know for a very long time. And I think this is a very encouraging story this patient has. I know this patient already for 11 years now. He was admitted to our neurology department, moving from another hospital to our department in September 2011. At that moment, he was 41 years old, so very young. He had a fastly progressive neurological symptoms in 3 weeks' time. And when he was admitted at our hospital, he had dysarthria, so difficulty speaking. He had a paraparesis. He could not move his arms or legs very well, so he was bedridden. And he had urine retention problems. And the diagnosis of Bing Neel syndrome was made on the findings of his cerebrospinal fluid combined with an MRI. And this patient was not known with Waldenström's disease, but we did do a blood examination and we found an IgM lambda M spike of 17 grams per liter. That's 1.7 grams per deciliter in the blood. And after we find that, we also did a bone marrow examination. And in histology, he had a 5 to 10% infiltration of Waldenström cells. So by definition, that should be an MCUS, but because he also had the Bing Neel presentation, we diagnosed him with Bing Neel syndrome and Waldenström's disease. And both diagnoses were new to this patient at that time. So this patient could not walk. We decided to treat him with chemotherapy and Rituxan, the anti-CD20 monoclonal antibody, 6 courses at that time. And we also treated him with intrathecal methotrexate because I think we were all very impressed by his fast presentation, and we wanted to do a maximal therapy for him. And his clinical recovery was really outstanding because after 1 course of rituximab fludarabine with MTX, he could leave the hospital already walking with aids, with a rollator. And I still see this patient, and if you don't know, you don't think anything is wrong with him because he doesn't have any neurological complaints. And only the neurologist tells me that there are still some minimal coordination difficulties in the legs, but that's it, and he doesn't notice it himself at all. Of course, during this rituximab fludarabine course, but also at the end, we performed the MRI. The MRI improved, never normalized, but improved dramatically. And also, I follow him all these years in the outpatient clinic. I only do history taking, physical examination, and some laboratory testing. And his IgM just normalized only recently in June 2022, so 11 years later. But he's doing fine and no relapse whatsoever at all. So that's a very positive diagnosis, a very positive finding. I published about this patient together with 3 other patients treated with fludarabine and with some help of other physicians. And here you see a graph of his IgM levels. So here it starts at September 2011. So this is his total IgM, not his separate IgM protein, but his total IgM. And you see a decrease over the years. And here he already stopped with treatment, but it was still elevated. But it slowly went down, down, down. And here you see the orange bar is normalized. And here you see the latest measurement point. He had a normalized IgM. I don't have a clear explanation for this because I do think that his disease was treated very well, and perhaps fludarabine also treats the systemic part of Waldenström very well. So I don't know exactly why this was there so long. I did not repeat a bone marrow examination. Perhaps that was the culprit, but we decided not to test him that rigorously and only to do what when complaints occur or reoccur. And until now, they didn't reoccur. So talking about treatment, I already talked a bit about fludarabine treatment. And one specific question was about the blood-brain barrier, the BBB. And that's some kind of a magical thing if we treat brain diseases, that if we administer drugs through the mouth or through in the bloodstream directly, we want to know if these drugs via the bloodstream will enter your brain, because there is the cancer or the disease. But for drugs to do that, they have to pass the blood-brain barrier. So what is a blood-brain barrier? Here you see how a normal blood vessel is composed. You see the endothelium. It's a one layer. These are active living cells. Here you see the nucleus of the cell. And this is the other cell. And between those cells, there are pores, there are openings, so there can be very easy transport of the content of your blood vessel into the surroundings. For example, your kidney, your liver, your heart, they all need of course, oxygen, but also glucose is very important to many tissue, but also other nutrients are very important. But in the brain, with the low regenerative capacity, there is an extra layer surrounding your endothelial layers. So in the brain, we are a bit more afraid, or we are built in a way that the brain is much more protective from anything passing the blood-brain barrier. And that's good, because the brain needs to be secured, because it's very important, of course. So what you can see is that there are hardly any pores in the blood between the cells of your blood vessels, but also this additional layer that's contained from brain cells is formed around your blood vessel. So two layers, very tight junction here. There is passage, of course, of glucose, oxygen, and also active transport is there from other stuff, but most of the stuff is not passing through the blood-brain barrier. So how are we then treating brain diseases? We do think that in brain disease itself, perhaps there are some disturbances of the blood-brain barrier. So perhaps there's more leakage than in normal situations. But what we also do is that we try to have high dosing strategies, and I will explain what it is later on. So that there is still, if you have a very high concentration in the blood vessel, there is still some diffusion inside your brain, but also to make use of very small molecules that can be actively transported over the blood-brain barrier, and therefore can be active in your central nervous system. So drugs that have to pass the blood-brain barrier can be very high dosed. And not all chemotherapy can be dosed very highly, but methotrexate is one of the drugs that can be dosed very high. And if you go above dosages of 3 grams per meter square, you can reach cytotoxic concentrations in your cerebrospinal fluid and via your fluid also in your brain itself. And previous studies have shown that the blood to CSF concentration is 30 to 1. So that means that the concentration in the blood is 30 times higher than in your CSF. So you must have very high concentrations in your blood to have an active concentration inside your central nervous system. And because this is so high dose, this chemotherapy is given inside the hospital. You have to be admitted for several days, because it can be toxic and you have to be watched and treated with special additives to prevent kidney and liver damage. Another drug that has the same principle is cytarabine. It's also active in lymphoma. And if you give high doses, then you also pass the blood-brain barrier. And these two drugs are typically given to patients with primary CNS lymphoma, which is a very aggressive form of lymphoma in your brain. And this was transferred to patients with Bing Neel syndrome. And there are many case reports in literature that this is an active drug, or both are active drugs. Normally you give 4 to 6 cycles. to have your Bing Neel session in remission, and then you can stop and go to wait and see again. So the drug that I used for my patient is called fludarabine. It's a purine analog, and together with cladribine and also bendamustine, it passes the blood-brain barrier already at lower dosage. So we think that there is a specific transport of these drugs into your brain, and therefore they can be active in Bing Neel syndrome. They are not so active in aggressive lymphoma. So these are typical drugs used in low-grade lymphomas, and they also belong to the classic chemotherapy arsenal. And then, of course, we have targeted therapy. And at the moment, that's mostly the BTK inhibitors, so the Bruton tyrosine kinase inhibitors. Ibrutinib I will talk more about because we have most information about Ibrutinib, but Ibrutinib now has two sisters. They are called zanubrutinib and acalabrutinib. And we also do know from zanubrutinib there are case reports, or one case report, that it can be active in Bing Neel syndrome. And I do think that also acalabrutinib can be active, but until now, no case reports has been, to my knowledge, has been reported that this also is active in treating Bing Neel syndrome. So Ibrutinib was published in a retrospective analysis from some hospitals in the United States by Jorge Castillo in 2019, in which they reported on 28 patients, so quite a big cohort, which were treated with single agent Ibrutinib on two different dose levels. So the higher dose, the 560 milligrams once daily, which is normally used for mantle cell lymphoma patients, and also the 420 milligram doses once daily, which is the standard Waldenström dosage was given by mouth, of course, once daily, and there was no difference in outcome. So we don't think that a higher dose is needed in Bing Neel syndrome patients. The Ibrutinib was the first BNS treatment in 39% of patients, so the majority of patients had previous treatments for their Bing Neel syndrome before, but the other ones was their first treatment. And I think the results are quite good because within 3 months of therapy, 85% of patients experience symptomatic improvements of their disease, and that's what's most important. That's counting tremendously to the effect. 60% had radiological improvement. So like my patients, not all the MRIs do normalize, but also not all the MRIs do improve. In this case, only 60%, and 58% also had cytological CSF clearance. So approximately 40% of patients still had some persistence of the cancer cells in their CSF, despite improvement of symptoms. And that's something that I think is typical for Ibrutinib or other BTK treatments, and it's something that you normally don't see with chemotherapy treatment. There, in those cases, the CSF is mostly cleared of the cancer cells. But importantly, also here is that also if the CSF still has some presence of the cancer cells, patients still reported improvement of their symptoms. So sometimes you have to be satisfied with what you can get, and don't well, those few cells that are still in your CSF, perhaps they are not doing that much damage, and you have to see how things evolve over time. The 2-year event-free survival probability was 80%, and that's also quite good. So in my mind, and also in the mind of Jorge and Steve Trion, who published this series, I think Ibrutinib is one of our most important drugs we have at the moment to treat Bing Neel syndrome. So what about safety? 13%, only 45% of the patients reported adverse events. And I think that's a problem that we see with retrospective analysis, because if you do a prospective study, most patients do report some adverse events. But these 13 patients mostly reported neutropenia and infections, and I think that's the problem with all our treatments. but also some bleeding. This bleeding was innocent, some bruising, but we have to be aware that in very large series of Ibrutinib treatment, for example, in chronic lymphatic leukemia, CLL, there has been a 4-fold risk increase of CNS bleeding. So with Bing Neel syndrome, I think that was one of the first fears that we had as physicians, that perhaps this could also increase CNS bleeding in Bing Neel syndrome, but until now it has not been reported. Of course, Bing Neel syndrome is not that frequent, but it's important to realize that you have an increased risk of bleeding also in the brain. Atrial fibrillation has a 20-fold increased risk in, again, large populations, treated with Ibrutinib for several indications, but was also reported in the small cohort of 28 patients. And also one patient had ventricular tachycardia, and that can be a fatal rhythm, cardiac rhythm disorder. And that risk is 5-fold increased when you use Ibrutinib. Other complaints were diarrhea, nausea, fatigue, muscle cramps, headaches, and strangely enough, hypertension was not reported as an adverse event, while we know that is one of the most common adverse events with Ibrutinib. So the safety report seems to be good. Of course, enhanced risk of atrial fibrillation mostly, but that's something that we know of this drug, and there were no special side effects seen. And also, I would like to have some words on Venetoclax, which is a BCL2 inhibitor. That's a new drug that is also used a lot now in patients with leukemia, both chronic leukemia, but also in acute leukemia. And because this is also a very small drug, people are looking if it can also be used to treat cancer, hematological cancers inside your brain or inside your central nervous system. In children, one study has been published that has demonstrated a very large plasma to CSF ratio of 300 to 1. So that seems that there's a very active blood-brain barrier preventing from Venetoclax entering your brain, because this is much higher than, for example, the methotrexate. And also were done some measurements of this drug in your CSF, so done with lumbar punctures, to see if they could measure Venetoclax in the CSF when it was taken by mouth, like you normally take this drug. And there it was even worse, because the CSF concentration was only 0.1% of your plasma cell concentration. So that means 1,000 to 1 ratio. So I do think the blood-brain barrier is keeping Venetoclax away from your brain. But the question, of course, still is there enough entrance? Can you dose high enough? And therefore, is there enough entrance into your central nervous system to treat diseases there? Clinical responses should follow then if you have an active doses inside your brain. But until now, only clinical responses have been described in 2 CLL patients and 1 acute leukemia patient who did have CLL or leukemia inside their brain, in their spinal fluid. But these patients were also treated with other combination treatment that could pass the blood-brain barrier. So we're not sure if it's Venetoclax or the other drugs that were active. And I could not find any study or description of a patient who was treated with Bing Neel syndrome and Venetoclax. So at the moment, I think it has potential for the future, but I can't recommend it as a standard treatment. Then what about CAR T cells? So CAR T cells are chimeric antigen receptor T cells, and that's very hot at the moment, and I think for the coming years in cancer treatment. So what do we do with CAR T cells? What we do is that we collect the T cells from the patients themselves. So we do a apheresis only to collect your T lymphocytes from the bloodstream. and they go to a manufacturing site where they are selected for the T cells, and there they are transduced. So with a viral factor, some additional DNA is brought into the cells, and this DNA codes for a receptor on the outside of the T cell. So this is a new receptor, and also for some activation domains. And this receptor recognizes cancer cells very good. So in this case, in lymphoma, it's a CD19, but you can construct every receptor you want. So for other types of cancer, it's another receptor. But then you make some kind of a super T cell out of it. And you multiply them, and then they are given back to the hospital in a small bag. And the patient is admitted to the hospital. The patient will receive some chemotherapy with fludarabine, but that is to treat your own immune system. And then after 3 days of fludarabine and some other chemotherapy, the CAR T cells are given back to you. So it's your own T cells, and they will, through this receptor, will try to find every cell which has a CD19 on its surface and will kill it. So it's a very effective drug. It's a completely new drug, and it's currently mostly used for patients with aggressive lymphoma, where it can cure diseases, and also in multiple myeloma, where it's also effective, but at the moment not curative. So what about Waldenström patients? Until now, 3 Waldenström patients have been described in literature that have been treated with the anti-CD19 CAR T cells. 2 patients responded with a complete response and also a partial response. And 1 patient did not respond. She or he had a stable disease. But all these patients relapsed from their Waldenström's disease. So it's not, it seems to work, but I don't think at the moment we don't have any idea if it can be curative and how long remission will occur, because also the side effects of these CAR T cells are, how I say that, they are there. You have to be admitted to the hospital, and they can be life-threatening, the side effects of CAR T cell treatment. So it's a very, very intense treatment. It's not, it can be given to all patients. What's important that CAR T cells are now being explored in high-grade brain lymphoma patients. And there we have much more experience. So there are already like 30 patients reported in literature. There it seems to be feasible, and the response rate is 60%. We don't have data yet on the durability of these responses. And we do think that there can perhaps be more severe neurological side effects. We call that ICANS in brain lymphoma patients. But these data will evolve in the coming years. But notice these are high-grade brain lymphoma, so not Bing Neel patients. And therefore, I do think that CAR T cells will not very likely soon to be used in Bing Neel patients. You can also treat Bing Neel directly into the cerebrospinal fluid. Normally, we do that with a lumbar puncture. Here you see how a lumbar puncture is done. So we try to move the needle between 2 vertebrae in, and here you see the CSF sitting there, and there it can be taken with a needle. Of course, a lumbar puncture is much more cumbersome than other treatments. It's not very effective in brain tumors because the brain is here, and if you inject here, it has to travel all over there in a very and the concentration is already very much lower. So it's more effective in meningeal diseases. And most BNS treatments, it's given as an additive and not as the primary treatment, because when you do that, it's also not very effective. You can also deliver chemotherapy in an Ommaya reservoir. There's no literature about that in Bing Neel patients, but acute lymphoma leukemia patients sometimes have this Ommaya reservoir implanted. So here you see the reservoir, it's on top of your brain. There's a small canule leading to your spinal fluid, and you can inject drugs directly into the cerebrospinal fluid, and also it's more located inside the brain. but again, not normally used in Bing Neel syndrome patients. Then what about clinical studies? I looked it up in the clinicaltrials.gov, but no studies have been published, prospective studies has been done or are in the planning until now. So that's pity. And we do, at the moment, we still gather our clinical information from retrospective analysis. So my treatment algorithm, I think, is the same as was proposed by Castillo et al. In his paper in 2019. When you make a diagnosis of Bing Neel syndrome, use of a biopsy, brain MRI, and CSF. Biopsy is not always done, but if it's done, it can be. It can also. It's the gold standard still. Most of the patients, of course, are symptomatic because why else would you do a lumbar puncture? And therefore they need treatment. And the preferred treatment option is Ibrutinib at the moment in the standard dosage of once a day, 420 milligrams. Other options, if Ibrutinib does not work or the patient is already progressing on for his Waldenström's or her Waldenström's on Ibrutinib, we have to look for other treatment options. And my experience, and also in the literature, is the highest experience are with fludarabine and high-dose cytarabine and high-dose methotrexate. So I think it's important that you have a physician with experience in this field because they can guide you through these chemotherapy cycles. Other recommendations is that rituximab, it can be added, but we don't know exactly if it passes the blood-brain barrier, but normally we do add it because we do think there is some effect there. Radiation therapy, I did not talk about, but it can be considered for very localized symptoms, especially when they are in the spinal cord. And like I explained, intrathecal therapy can be considered if there's leptomeningeal disease only, and if patients are really not in a good shape for systemic treatment. After treatment, it's very important to monitor your response to treatment, and clinical presentations is the most important parameter for that. Your clinical symptoms should improve. So before you start treatment, make a list, what are your clinical symptoms, and they should improve. There's one problem, especially with the chemotherapy, so not that much with Ibrutinib, but with the classical chemotherapy, because they pass the blood-brain barrier so well, you can have some neurotoxicity of the treatment itself. So that's something that occurs very rarely, but it can occur. So when your symptoms are improving, again, we need a neurologist and a radiologist to help us determine if it's progression of Bing Neel syndrome, switch treatment, or is it a neurotoxicity of the treatment? And perhaps then we should wait a bit more for this neurotoxicity to improve by itself by stopping treatment. Your spinal fluid ideally should clear of the Waldenström cells because that indicates effective therapy. But like I explained, that's not always the case with BTK inhibitors like Ibrutinib. Then it's less important, and importantly also in that same paper it was shown that the clearance of Waldenström cells had no relation with survival. You can also measure the MYD88 mutation with a PCR, and at the moment we don't have data if we can follow clearance or effect of therapy with this PCR. So that's a question mark. We do the spinal fluid examination if you're on chronic therapies. On a chronic therapy, perhaps in the beginning, once every 3 to 6 months. If you are on a psychotherapy, you normally do it halfway and at the end. And if the spinal fluid is cleared or it's a stable situation, only repeat that on indication. So when complaints are increasing again. The MRI should be contrast enhanced. Of course, you do that before you start therapy. And then again, in a stable situation. MRIs do not always normalize. Don't be frightened by that. That's a situation we normally see. And that's because sometimes some damage still can be seen on the MRI. It doesn't mean your disease is still there. And only repeat the MRI when there is suspected progression or relapse of your disease. And then your serum IgM or your IgM monoclonal protein, normally that is followed every time you go visit your hematologist. If we are giving effective systemic therapy like chemotherapy, like Ibrutinib, it should also decrease. Then we also know that we are doing a good thing, that the Bing Neel syndrome should be sensitive to this type of treatment. And it was not a goal of treatment, but I think it's always nice to have that also your systemic Waldenström disease is more in remission when you start BNS treatment. So how important is response for survival? Like I already explained from this paper, you see here an overall survival plot. So you see patients that after the year of diagnosis, in the beginning, patients die, but in the end, there are also many patients that have a more longer survival over the years. And in the surviving group of patients, 40% of them had evidence of a pathological, so in their CSF, or radiological persistence of their disease on the MRI. So also in these surviving patients, 40% still had some abnormalities on their MRI, but did not have a relapse of their disease. And with that, I'd like to thank you very much for your attention. I hope you have a great day together, and I hope that we can see each other in person another time. Thank you very much.